Hello guys, hello. How are you? So now I am going to learn pathology, peripheral and nervous system. So yeah, let's learn. Mononeuritis multiplex vasculitis, randomly damaged individual nerves, wrist drop, and left foot drop. Mononeuropathy, traumatic injury, carpal tunnel syndrome or Lyme disease, CIHD, that is chronic inflammatory. What is the form of CIHT? Okay, Guillain-Barré syndrome. It is basically what is Guillain-Barré syndrome? Guillain-Barré syndrome. Yeah, it is immune-mediated autoantibody demyelination, ascending weakness from leg up, death from failure of respiratory muscles over a period of only several days. Okay, chronic inflammatory demyelinating polyneuropathy (CIPD). Muzaffar. CIDP. Okay. Hmm. And it is called by the aliens called as Campbell-Batter jejuni, Epstein-Barr virus, cytomegalovirus, and HIV. Okay. Let's just write it down. Cytomegalovirus and HIV. So the injury is most extensive in nerve roots and proximal nerve segment and is associated with mononuclear cell infiltrates rich in macrophages. Both human and cellular immune responses are believed to play a role in the disease process. Okay. Symptoms: weakness or tingling sensations in both legs. Many times this spreads to arms and upper body. Symptoms may increase until some muscles cannot be used at all, and in severe cases the person can become paralyzed. Symptoms can progress over hours, days, or weeks, and weakness typically peaks within the first 2 weeks after symptoms appear. Recovery may take as little as few weeks or as long as few years. Patients who survive the initial acute phase of disease usually recover with time. Chronic inflammatory demyelinating polyneuropathy. Okay, CIDP. CIDP, not CI. CIDP. Both sensory and motor abnormalities are seen in the CIDP. Both motor, okay, like difficulty in walking, weakness, numbness, and pain, or tingling sensation, like Guillain-Barré syndrome. CIDP is immune mediated and occurs at increased frequency in patients with other immune disorders like systemic lupus erythematosus and HIV infections. In contrast with Guillain-Barré syndrome, however, CIDP follows a chronic, relapsing, remitting, or progressive course. The peripheral nerve shows segments of demyelination and remyelination in long-standing cases. Chronically regenerating Schwann cells may concentrically wrap around axons in multiple layers in an onion ski pattern. Onion, onion ski pattern is important. Onion ski pattern. Okay. So, what is the difference between chronic inflammatory demyelinating polyneuropathy and Guillain-Barré syndrome? So, GBS is one of the two neurological emergency patient needs to be monitored closely during the initial acute phase of illness. In contrast, CIDP is a slowly progressive illness with diffuse sensory and motor symptoms. GBS presents with much more acutely and reaches and its most severe state in less than 4 weeks. CID presents more slowly and reaches its more severe state typically in over 8 weeks. Okay. Because of this, GBS is considered a classical autoimmune neuropathy, while CIDP is a classic chronic autoimmune neuropathy. Okay. Diabetic peripheral neuropathy. Diabetes is the most common cause of peripheral neuropathy. Types: autonomic neuropathy and lumbosacral reticulopathy. Okay. Diabetic peripheral neuropathy. Okay. Diabetic peripheral neuropathy. So there are two types of diabetic peripheral neuropathy: autonomic neuropathy and lumbosacral reticulopathy. Okay. Autonomic, autonomic and lumbosacral. Lumbo reticulopathy. Reticulopathy. Okay. Autoimmune neuropathy, lumbosacral reticulopathy, and distal symmetric sensory motor neuropathy. These may also similar together. Autoimmune neuropathy is characterized by change in bowel, bladder, cardiac, or sexual functions. Okay, so autoimmune neuropathy is characterized by change in bowel, bladder, cardiac, or sexual functions. And distal symmetric sensory motor polyneuropathy. Okay. And also distal Symmetric. Sensory. Sensory motor polyneuropathy. Autonomic neuropathy is okay. So autonomic neuropathy is caused by change in bowel changes. Bladder, cardiac, or sexual functions. Sexual functions. Lumbosacral radical manifest with asymmetric pain that can progress to lower extremity weakness and muscle atrophy. Asymmetric pain. Lumbosacral radiculopathy is characterized by the asymmetric pain can progress to lower extremity and muscle atrophy. Muscle atrophy, muscle atrophy. And distal symmetric sensory motor neuropathy is the most common form of. Okay, this is the most common form of most common form of diabetic okay. So sensory axons are more severely affected than motor neurons. So clinical presentation usually is dominated by paresthesia and numbness. Okay. Sensory axons are more affected. Okay. So sensory axons are more severely affected than motor axons. So clinical presentation is usually dominated by paresthesia and numbness. Paresthesia and numbness. The paresthesia and numbness paresthesias and numbness. Okay. So the pathogenesis of diabetic neuropathy is complex accumulation of advanced glycosylation end products, hyperglycemia, increased levels of reactive oxygen species, microvascular changes in the axonal metabolism, abnormal protein C levels, and neurotropic factors all have been implicated. So the cause, okay. Let me display we talking sacrament. Toxic and inherited forms of peripheral neuropathy. Drugs and environmental toxins that interfere with the axonal transporters or cytosol function often produce peripheral neuropathies. Peripheral nerves are often damaged in many different forms of okay. Hmm. Vagina granulomatous. The most common clinical feature is that of a mononeuritis multiplex with a painful asymmetric mixed sensory motor peripheral neuropathy. Inherited diseases of peripheral nerves are heterogeneous but relatively common group of disorders. With a prevalence of 1 to 4 in 10,000, they can be demyelinating of axonal. Many such disorders manifest in adulthood and follow a slow, slowly progressive course that may mimic that of acquired polyneuropathy. The most common cause of mutation in genes. T. Hmm. So, disorders of neuromuscular junction. The neuromuscular junction is a complex specialized structure located at the interface of the motor nerve axons and skeletal muscle that serves to control muscle contraction. Here the distal ends of peripheral motor nerves branch into small processes that terminate in bulbous synaptic bordens. Nerve impulses depolarize the perisynaptic membrane, stimulating calcium influx and the release of acetylcholine into the synaptic left. Acetylcholine diffuses across the synaptic left to bind its receptor on the postsynaptic membrane, causing depolarization of the myofiber and contraction through electromechanical coupling. Often disorders of neuromuscular junction provide functional deficits in the absence of any significant alteration in morphology beyond ultrastructural changes. Considered in this section are some of the more common or pathologically interesting that disrupt the transmission signal across the neuromuscular junction. Myasthenia gravis, yeah. Myasthenia gravis disorder that disrupt the transmission of signal across the neuromuscular junction. Myasthenia gravis is caused by autoantibodies that block the function of a postsynaptic acetylcholine receptor at motor end plate, which causes degradation and depletion of receptors. ठीक है. Clinically, myasthenia gravis frequently manifests with ptosis, drooping eyelid, or diplopia, double vision because of a weakness of extraocular muscles. This pattern of weakness is distinct different from that. Okay, so this pattern of weakness is distinctly different from that of most primary myopathic diseases in which there is a little sparing of facial and extraocular muscles. The severity of weakness often fluctuates rapidly, sometimes over a period of a few minutes. Characteristically, rapid, rapid, repetitive firing of muscles makes the weakness more severe, whereas the cholinergic inhibitor improves strength markedly. Features that are diagnostically useful. Effective treatment include cholinergic inhibitors, immunosuppression, plasmapheresis, and inhibition with thymic lesions, thymectomy. These interventions have improved the 5-year survival rate to greater than. Nice. Okay. Pathogenesis of myasthenia gravis, genetic predisposition, axillary CTILA4, T, others, thymic hyperplasia, antigens ACR into 9 CD4 plus cells, drugs, checkpoint inhibitors like penicillamine, interferons, statins, others they cause T, MBC, and T. Okay. Hmm. Lambert-Eaton syndrome. Lambert-Eaton syndrome is caused by autoantibodies that inhibit the function of a presynaptic calcium channels, thereby reducing the release of acetylcholine into the synaptic cleft. Patients with Lambert-Eaton syndrome experience improvement in weakness. Oh, acha, okay. So there is some difference in Lambert-Eaton and myasthenia gravis. In myasthenia gravis, the patient, the patient, like how to what car? Hmm. Myasthenia gravis frequently manifests with tosses, drooping eyelid, or diplopia because of weakness in the extraocular muscle. This pattern. Hmm. Repetitive firing of muscles makes weakness more severe. Okay. Hmm. And in the Lambert-Eaton syndrome, the improvedness in weakness with rapid repetitive stimulation. Okay. Hmm. So to build up. Okay. Okay. Hmm. Okay. So different between Lambert-Eaton syndrome and myasthenia gravis. So myasthenia gravis has antibody against acetylcholine receptor antibody. Okay. And the antibody against voltage gated calcium channel. Voltage gated calcium channel. Okay. Myasthenia gravis associated with thymic tumor associated with small cell lung cancer. Okay. Weakness worsen on huh. Okay. And normal deep tendon reflex decrease or absent deep tendon reflex. Autonomic dysfunction is absent or autonomic dysfunction is present. On there is gee. Okay. Simple है. Congenital myasthenia syndrome or a heterogeneous group of diseases that cause mutation that disrupt the function of various neuromuscular junction proteins. Depending on the affected protein, the defects may occur at the level. Hmm. Gee. Okay. Hmm. Infection with the exotoxin producing bacteria may be associated with defects in neurotransmission and muscle contraction. Clostridium tetani and Clostridium botulinum both release extremely potent neurotoxins that interfere with the neurotransmission. Okay, so see, there are different types of disorders of neuromuscular junction. We have five types: myasthenia gravis, then Lambert-Eaton syndrome, and congenital malformation of the neuromuscular junction, bo- botulism, and tetanus. Yeah. So so Tetanus is caused by the toxin Clostridium tetani, and this toxin actually inhibits the inhibiting neuron, therefore stimulating the lower motor neuron, and therefore causing the spastic paralysis. Ah, okay. And Botox, botulinum, it actually inhibits the acetylcholine release from the pre-synaptic receptors. So therefore uh, this botulinum toxin, it causes flaccid paralysis. Okay. Hmm. Okay. ठीक है. Hmm. The principal component of motor system is the motor unit, which is composed of one lower motor neuron together with the associated axon. Its neuron. Okay. Cerebral muscle consists of different fiber types, broadly classified as slow twitch type 1 and fast twitch type 2. Slow twitch type 1 and fast stitch type 2. Slow stitch type 1 and fast stitch type 2. Okay. ठीक है. The fiber type is dependent on the innervation. All myofibers of motor unit therefore share the same fiber type. Normally, the fibers of different types are distributed in checkerboard pattern. A number of proteins and protein complexes and are crucial for the unique structure and function of skeletal muscles. These include protein that make up and dystrophin glycoprotein complex, as well as enzymes that allow muscle to meet its unusual metabolic requirements. Hmm. Primary muscle diseases or myopathies have to be distinguished from secondary neuropathic changes caused by disorders that disrupt muscle innervation. Both are associated with altered muscle function and morphology, but each has a distinctive feature. Myopathic conditions are often associated with segmental necrosis and and regeneration of individual muscle fibers. Some myopathies are also associated with other morphological features like inflammatory infiltrates or intercellular inclusions. Destruction of muscle by endomyosial fibrosis and fatty replacement is reflective of disease chronicity that can occur both in myopathy. ठीक. Hmm. Both neuropathy and myopathy processes cause muscle fiber atrophy. However, certain disorders are associated with particular patterns of atrophy as follows. Neuropathy changes, loss of innervation causes. ठीक. Wait. थोड़े से क्या. Okay. So, both neuropathic and myopathic processes cause muscle fiber atrophy. However, certain disorders are associated with particular patterns of atrophy as follows. Neuropathic changes, loss of innervation causes atrophy of myofibers. The two main morphology hallmarks of neurogenic changes, grouped atrophy and fiber type grouping, are the result of multiple rounds of denervation and reinnervation. Loss of an axon or lower motor neuron results in atrophy of myofibers. Huh, okay. Atrophic myofibers can be re-innervated by axonal branches from adjacent motor units, increasing the size of these motor units and returning traffic in. Yeah. Multiple rounds of denervation and reinnervation result in a cheap. Muscular dystrophy is muscular dystrophy. Okay. Okay. So mutation in dystrophin are associated with X-linked Duchenne and Becker muscular dystrophy. Okay. P. Dystrophin, dystrophin, mutation, X-linked Duchenne and Becker muscular dystrophy. Caveolin, sacroglycal, sarcoglycan, autosomal, limb, girdle, and alpha 2 laminin, myrcin, okay. So, uh, dystrophinopathies are most common form of muscular dystrophy. Duchenne muscular dystrophy and Becker muscular dystrophy are the most common muscle diseases. Manifestation linked to mutation in the dystrophin gene. Dystrophin gene located on the short arm of X chromosome XP21. Dystrophin is a very large protein, 427 kilodalton in molecular weight, found in skeletal muscle and cardiac muscle, brain and peripheral nerves. It is part of a dystrophin glycoprotein complex. This complex stabilizes the muscle cell during contraction and may be involved in cell signaling through interaction with other proteins. Dystrophin glycoprotein complex defects are thought to make muscle cells vulnerable to transient membranous during contraction that causes calcium infarction, and they may also disrupt intracellular signaling. Okay. Often the first symptom of DMD are clumsiness and okay. The weakness typically begins in period and okay. Mm-hmm. 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 Okay. Mm-hmm. ओके, ठीक. So, triad of inflammatory polymyopathies. Inflammatory myopathies. Polymyositis. Increase in body myositis. Treatment with the corticosteroids, cortico and immunosuppressive agents. Children. Paraneoplastic diseases. Autoimmune diseases. Autoimmune diseases. Microscopic perivascular mononuclear cell infiltrates with plasma cells. With drop out of capillaries. Myofibrotic damage. Autoantibodies. Toxic myopathy. A number of insults can cause toxic muscle injury, including intensity thyroxine and extrinsic factors like acute alcohol intoxication. Drugs thyrotoxic myopathy may take the form of either acute or chronic proximal muscle weakness and can be the first indication of thyrotoxicosis. Histology findings include myofibrocnecrosis and regeneration. Ethanol myopathy occurs after an episode of binge drinking. The degree of rhabdomyolysis may be severe, sometimes leading to acute renal failure secondary to myoglobinuria. Patients usually okay. Hmm. ठीक है. Drug myopathy. Distracting. Peripheral nerve tumors. Neurofibromatosis type 1. Neurofibromatosis type 1. And type 2. Okay, guys, that's it for today. Thank you. Bye bye.